Hello, my name is Dr. Alexia Gaffney. I am a triple board certified infectious disease physician, and I am a breast cancer survivor thriver. I'm here to speak with you all today about my experience as a breast cancer patient and what I learned and experienced as a patient and a survivor. So I was diagnosed with stage 3 right invasive lobular carcinoma and underwent bilateral mastectomy, chemotherapy with adriamycin and cyclophosphamide, followed by Taxol and 25 cycles of radiation therapy. The pathology from my mastectomy also revealed that I had stage 1 invasive lobular carcinoma. Now, my story is interesting in that my breast cancer diagnosis was 2 years in the making. At 35, I found a lump in my left breast on routine self-breast examination, and ultrasound was concerning enough for me to undergo a biopsy. That biopsy showed findings consistent with LCIS, and I subsequently underwent a lumpectomy. The pathology on the lumpectomy revealed LCIS, atypical lobular hyperplasia, and fibroadenomatous changes. As a result, I was continuously followed by both a breast oncologist and breast surgeon, and went into the cycle of every 3 months breast imaging with mammograms and ultrasounds alternating with breast MRI imaging. After repeated episodes of abnormal imaging, biopsies, lumpectomies, at the advice of my primary care doctor, I requested a prophylactic bilateral mastectomy. I was told that prophylactic bilateral mastectomy was too radical, and I requested genetic testing in the hopes that if I had a gene mutation, it would make me a candidate for prophylactic surgery. I was denied the genetic testing, and on the grounds of I had not had a significant enough family medical history of cancer. And so when I was diagnosed with bilateral breast cancer at 37, I became a candidate for genetic counseling and testing. And it turns out that I'm a PALB2 mutant and that I have an ATM gene variant of indeterminate significance. So one of the things about my story that is disconcerting is that as a young African-American woman, and knowing that African-American women have the highest breast cancer mortality in the United States, being denied a prophylactic surgery and genetic testing just seemed like a disservice. We know the data, we know the statistics, we know that Black women are more likely to be diagnosed with breast cancer at a younger age, that it is more likely to be aggressive, and that our mortality rates are 42% higher than our white counterparts. So in spite of all of these facts, I was still left with the breast that I and my primary care doctor had asked to be removed. I was told that, again, the mastectomy was too radical and I didn't qualify. But my question to you all as providers is, anything too radical for a young woman whose cancer is more likely to be aggressive and more likely to kill her? So for me, what I experienced was a serious disconnect between how clinical data was applied to me as a young Black woman, and I have concerns about how often that happens to women in other minority groups. So just as an example, only 40 to 60% of Black and minority women are offered genetic testing and counseling when they're diagnosed with breast cancer or other hereditary cancers. Sometimes lack of cultural competency can get in the way of taking care of Black women and certain other minority groups. So one of the things that I'm very cognizant and aware of is that sometimes there's no family history of cancer because certain cultural groups consider it taboo to talk about family medical history or to discuss family business. And we have to be mindful of the fact that prior generations experienced lack of access to quality medical care. This is especially true for Black Americans in the United States. And it continues to be an issue today. The other thing is that patient care is often complicated or compromised by certain stereotypical beliefs that we learn during our training, and that impacts the management of patient care. Some examples are the notion of a strong Black woman, or describing a Latina woman as being in status Hispanicus when they express concerns about their own health or well-being, or when they express pain. Also, as a Black woman, I'm very cognizant of the idea of being perceived as an angry Black woman. And so sometimes I back down or withhold, or I may not advocate for myself in the way that I should. This combination of beliefs and this lack of consideration for these kinds of issues have the potential to result in harm to our patients, result in inadequate response to symptoms or clinical concerns, and can result in adverse events for a patient. On the other side of it, my experience and the experience of other Black women in the breast cancer community is that we often are not prepared for the cancer treatment experience. Understanding the patient's pain points, stressors, and concerns as a healthcare provider can help you all better address the patient's concerns during their cancer care. When I discussed with my Pink Sisters what were their areas of concerns or what they would like providers to know about their cancer care experience, some of the subjects that often came up is that patients felt like they had culturally insensitive care. So an example that I repeatedly heard and something that I experienced was when it came to products and services that I needed as a young Black breast cancer survivor. I was given catalogs or books and pamphlets with wigs that were centered for white women, hair that did not look anything like my hair, as well as hair that was not appropriate for a young woman. So because we were getting diagnosed at younger ages, it was very challenging to be on the receiving end of pamphlets, materials, hair prosthesis for a woman not of my age, a woman not of my race, and a woman not of my culture. I often felt like my pain was inadequately managed, and many of my sisters echoed this experience. Just as an example, I remember being hospitalized after my bilateral mastectomy and being in severe pain, having challenges getting out of bed and walking, having challenges getting up to the bathroom, and doing something as simple as flushing the toilet. And I remember a resident coming in to evaluate me overnight, and I complained of pain. And when he walked in, I had been sitting scrolling on my cell phone. And when he left after he discussed my pain with me, I just recall very clearly how we had always been taught that patients that are in 8, 9, 10 out of 10 pain are not, well dressed, they're not well groomed, they're not sitting comfortably talking on the phone or scrolling on their cell phones. And that was exactly what I was doing to distract myself from the pain that I had experienced from this major surgery 24 hours before. It would take until the following morning for my pain to be adequately addressed by my attending physicians. And so I always wondered, did that play a role in the management of my pain? And how many other women's pain management or other aspects of their care are impacted by these false beliefs that we have about what a patient looks like in pain, or these false ideas and beliefs that certain that people of certain races or certain ethnic minorities can tolerate pain better than their white counterparts. The other thing that I experienced was a dismissal of the impact of fatigue and cognitive dysfunction that I had. Now, as a physician, especially an infectious disease physician, I don't have any billable procedures. All I have is cognitive function, the ability to think of diagnoses that other folks aren't thinking about. And it was cognitive dysfunction and fatigue that took me out of work before neutropenia and other complications of my chemotherapy would have. Oftentimes, these symptoms are not acknowledged. Patients aren't made aware that these can be issues that might arise and may impact their ability to continue to work. For young women of color, infertility was often not discussed, and young women were often not offered preservation of their fertility. And this was a major source of dissatisfaction for young women. Sexual dysfunction often was not discussed as well as a result of chemotherapy and ongoing hormone suppressive therapy. Things that are very important and very relevant when you're talking to a younger patient population. And then lack of dietary and nutritional support. So while we know that our oncologists are not dietitians and nutritionists, many women felt that their diet and their lifestyle was very much a part of their cancer treatment and care and would have liked resources. And then lastly, being left to seek financial support and resources on our own as patients. So Black patients are more likely to experience financial hardship and bankruptcy as a result of a cancer diagnosis. This is often what leads many people to continue to work through their cancer treatment in spite of its hardship, but it also is a major stressor, and it can lead patients to appear to be non-compliant because treatment interferes with their ability to work and take care of themselves and their loved ones or provide for a household. Additionally, patients want a better understanding of their disease. Younger patients, savvy patients understand that breast cancer is not one singular diagnosis, and they want the details of their pathology. And oftentimes providers aren't forthcoming with that information, and it kind of leads to a general distrust for patients. Patients want a better understanding of their surgery. They want a better understanding of how they can prepare their bodies for surgery if there's time for that. And they want to know how they can prepare their family and their homes for surgery, which is very important when it comes to recovering during cancer treatment. Patients want prevention and management strategies for the side effects of their chemotherapy. And again, these aren't often discussed. So things like cool capping, icing of the hands and feet to prevent neuropathy from Taxols are things that we don't often hear from our providers, but that we hear from one another. And so we would love it if this kind of information would come from our doctors, our nurse navigators, our care coordinators, someone within the cancer treatment centers where we're seeking our care. And lastly, something that I, as a provider, find myself reminding my Pink Sisters and fellow breast cancer survivors is that although we as patients may have a particular agenda during our follow-up visits, so do our providers. They have a standard of care that they must meet, and certain things must be done during the visits. But patients will often feel dissatisfied with care because they don't feel seen or heard, because their concerns are not typically addressed during follow-up visits. So it's just another thing to be mindful of. So when we think about how all of these things come together and impact patient outcomes, something that I want to be careful to remind us all as providers is that no one really wants to be a non-compliant patient. Patients do want some level of autonomy and control. And people really want to make informed decisions, but a lot of times we simply tell the patient what kind of surgery they're going to have, because that is the surgery that their center or their surgeons are best at or most comfortable with or do most often. We want guidance on complementary care. We want safe and holistic and alternative approaches to managing our cancer experience and chemotherapy side effects. And we want that information to really come from the folks who are taking care of us. If not, patients are left to seek information within and outside of their cancer communities. And unfortunately, there's loads of bad information out there and lots of folks preying on cancer patients to potentially, make money off of them. And I see it time and time again. And I have experienced people approaching me in those kinds of ways. I'm lucky in that I am a healthcare provider, and I know when something is misinformed, falls outside of the standard of care, and just frankly isn't good medicine. But some of our patients and lay individuals may not. So it's just something to be mindful of. Lastly, just to return to the previous slide, when I mentioned about hair prosthetics, other things that are often not culturally competent or do not take into consideration Black women and brown women and women from minority populations are, the breast prostheses we might receive, our lymphedema sleeves and garments, and even seeing pictures and photographs of women with Black, brown, yellow skin, ethnic minorities in post-operative pictures and examples that we are being shown in the midst of our cancer care and when we're going through breast surgical and plastic surgical care. Often we don't see bodies that look like us. We don't see women who represent us in the information that is being shared with us. And that's so important to keep in mind. Lastly, the COVID-19 global pandemic has only added to the complexities of the cancer patient experience. We're seeing minority communities hit the hardest by this infection, and we are seeing a compounded impact in the cancer community, and that less individuals are showing up for cancer screening and cancer care. And so we know that there will be an increase in the number of cancer deaths and an increase in the amount of cancer mortality as a result of the COVID-19 pandemic. So as a physician, as a patient and even as an infectious disease specialist, it is my request that we consider how we can make special accommodations for the care of these most vulnerable patient populations. I am so grateful for you all's time and attention. I thank you for allowing me to share some of my story with you, and I look forward to speaking with you all during the question and answer session. Thank you.